So today I want to give you some information about your asthma and some of the programs, specifically the NAEPP, which is a program that deals with asthma specifically. Um, and I want to give you some information on how to control your asthma. So first I'm going to talk about the NAEPP, which stands for the National Asthma Education and Prevention Program. So first, the NAEPP was initiated in March of 1989 to address the growing problem of asthma in the U.S. The goals of the NAEPP are to raise the awareness of patients, health professionals, and the public that asthma is a serious chronic disease. They also want to ensure the recognition of the symptoms of asthma by patients, families, and the public, and the appropriate diagnosis by health professionals. Lastly, they also want to ensure effective control of asthma by encouraging a partnership among patients, physicians, and other health professionals through monitoring treatment and education programs. The ultimate goal of the NAEPP is to enhance the quality of life for patients with asthma and decrease asthma-related morbidity and mortality. Secondly, I want to give you some of the objectives that the NAEPP has specifically for patients and the public, and then also differently for health professionals. So first, for patients and the public, they want to increase public awareness, of course, of asthma as a significant public health problem. They want to also increase public awareness of signs and symptoms of the asthma, and they want to improve the knowledge, attitudes, and skills of patients regarding the detection, treatment, and control of asthma, particularly in high-risk populations. They want to define the guidelines for effective asthma education programs and promote development, dissemination, and the use of patients and family education materials. So for health professionals, they want to increase the knowledge, attitudes, and skills of all health professionals regarding signs, symptoms, and management strategies for asthma. They want to encourage the health professionals treating patients with asthma to adequately track and monitor patient status and to use objective measures of lung function. They want to assist and encourage health professionals, professional schools, and continuing education programs to include up-to-date and accurate information on diagnosis, pathogenesis, and treatment of patients with asthma. They want to promote and encourage the concept of active patient participation with the physician in the management of asthma, and develop resources and materials for use by health professionals. Lastly, they want to promote research to answer unresolved questions by underlying causes of asthma and appropriate asthma treatment and management practices. So next I want to talk to you a little about some of the clinical issues that comes along in diagnosing and management of the asthma. First, they want to establish an asthma diagnosis. That's one of the key clinical activities that they want to do. They can do these by using medical history and physical examination to determine that symptom of recurrent episodes of airflow obstruction that are present. They can use a spirometry in all patients greater or over the age of 5 years of age to determine the airway obstruction and at least partially reversible. Lastly, they want to consider alternative causes of the airway obstruction. Next, I want to talk about managing your asthma long term. So there's two goals that particularly I want to talk about. One, for asthma therapy, you want to control it. You can do this by reducing your impairment and reducing your risk. So first, you can control by reducing your impairment by preventing chronic and troublesome symptoms like coughing, breathlessness in the daytime, in the night, or after exertion. They require infrequent use, generally less than 2 days a week, of inhaled short-acting beta agonists for quick relief of symptoms. Next, they want to maintain near normal pulmonary function and maintain normal activity levels, like including your exercise or any other physical activities that you do. They also want to meet the patient's and family's expectations of and satisfaction of your asthma care. The second one was reduce risk. So they can do these by prevent recurrent exacerbations of your asthma and minimize the need for any emergency department visits or hospitalizations. They can prevent the loss of lung function for children, prevent reduced lung growth. Lastly, they can provide optimal pharmacotherapy with minimal and no adverse effects of therapy. There are 4 components of care: assessment and monitoring, education, control, environmental factors, and medication. First, assess the asthma severity to initiate therapy. Assess asthma control to monitor and adjust the therapy by obtaining the lung functions by spirometry at least every 1 to 2 years. You want to schedule a follow-up care as asthma is highly variable over time. For education, you'll want to teach and reinforce the patient. I'll want to teach and reinforce to the patient. This can include taking the medication correctly with inhaler techniques and avoiding environmental factors that worsen the asthma. Next, with education, we'll want to agree on treatment goals and address patient concerns while using a variety of educational strategies and methods. Controlling environmental factors is very important to control exposures to allergens and pollutants or irritants that make asthma worse. For patients who have persistent asthma, considering allergen immunotherapy and influenza vaccine for patients over 6 months of age. For medications, use a stepwise approach to identify appropriate treatment options. Inhaled corticosteroids, or ICSs, are the most effective long-term control therapy. So when choosing among treatment options, consider domain of relevance to the patient, patient's history of response to the medication, and patient's willingness and ability to use that medication. The stepwise approach and recommended treatments are meant to assist, not replace, the clinical decision making necessary to determine the most appropriate treatment to meet the individual patient's needs and circumstances. So to achieve control of asthma, there's a certain sequence of activities that's recommended. So one, for patients who are not already taking a long-term controlled medication, you want to assess the asthma severity and initiate therapy according to the level of severity. Before stepping up, review the patient's adherence to the medications, inhaler technique, and environmental control measures. To maintain the control of asthma, a regular follow-up contact is essential. They want to schedule a patient contact at 1 to 6 month intervals. The intervals will also depend on such factors as the level of duration of asthma control and the level of treatment required. For all age groups, incorporate 4 components of care: the medications, patient education, environmental control measures, and management of comorbidities. Next, you want to initiate the therapy based on asthma severity and adjust the therapy based on asthma control. If you're having difficulties managing your asthma, you can refer to your asthma specialist. So for a daily long-term control therapy for ages 0 to 4, it's recommended recommendations, it should be considered for reducing risk in infants and young children who have 2 exacerbations requiring systemic corticosteroids within 6 months. The decision about when to start long-term daily therapy is difficult. The chronic airway inflammatory response in asthma can develop in preschool years. For example, between 50 and 80% of children who have asthma develop symptoms before their 5th birthday. Adequate treatment will reduce the burdens of illness, and underdiagnosis and undertreatment are key problems in this age group. Not all wheeze and cough are caused by asthma, however, and caution is needed to avoid giving appropriate prolonged therapy. For ages 5 to 11, want to promote active participation in physical activities, exercise, and sports, because physical activity is an essential part of a child's life. You also want to directly involve children over the ages of 10 or younger, if it's as appropriate, in developing their written asthma action plans and reviewing their adherence. For ages 12 and older, they want to encourage the students to take a copy of a written asthma action plan to to school or after-school activities. They would assess the possible benefit of treatment in older patients. Some treatment strategies to prevent exercise-induced bronchospasms should first include long-term control therapy or pre-treatment before exercise with a short-acting beta agonist. In the pregnancy stage, maintaining lung function is important to ensure oxygen supply to the fetus. Budesonide is preferred because the medication has the most data during pregnancies. To reduce the risk complications during and after surgery, a short course of oral systemic corticosteroids may be necessary. Effective management of exacerbations incorporates the same 4 components of asthma management used in managing asthma long-term: assessment and monitoring, patient education, environmental control, and medications. Early treatment by patients at home is the best strategy for managing asthma exacerbations. Patients should be instructed how to recognize early indicators of an exacerbation, including worsening PEF, using a written asthma action plan that notes when and how to treat signs of an exacerbation. A peak flow-based plan may be particularly useful for patients who have difficulty perceiving airflow obstruction or have a history of severe exacerbations. Adjust their medications by increasing short-acting beta agonists and, in some cases, adding a short course of oral systemic corticosteroids. Doubling the dose of the ICSs is not effective. Remove or withdrawal from allergens or irritants in the environment that may contribute to the exacerbation. Monitor response to treatment and promptly communicate with the clinician about any serious deterioration in symptoms or PEF, or about decreased responsiveness to the short-acting beta agonist treatment, including decreased duration of effect. Management in the urgent or emergency care setting should have pre-hospital protocols that allow administration of the short-acting beta agonists to reverse airflow obstruction rapidly, supplemental oxygen to correct significant hypoxemia in moderate or severe exacerbations, and, with appropriate medical oversight, anticholinergics and oral systemic corticosteroids to decrease airflow inflammation in moderate or severe exacerbations, or for patients who fail to respond promptly and completely to short-acting beta agonist treatment, to patients who have signs or symptoms of an asthma exacerbation. And remember to monitor response to therapy with serial assessments. Differential diagnostic possibilities for asthma should be considered. Recurrent episodes of cough and wheezing most often are due to asthma in both children and adults. However, other significant causes of airflow obstruction leading to wheeze must be considered both in the initial diagnosis and if there is no clear response to initial therapy. Additional pulmonary function studies will help if there are questions about COPD, diffusing capacity, or a restrictive defect, measuring of lung volumes, or VCD, evaluation of inspiratory flow and volume loops. Bronchoprovocation with methacholine, histamine, cold air, or exercise challenge may be useful when asthma is suspected and spirometry is normal or near normal. For safety reasons, bronchoprovocation should be carried out only by a trained individual. A positive test is diagnostic for airway hyperresponsiveness, which is a characteristic feature of asthma, but can also be present in other conditions. Thus, a positive test is consistent with asthma, but a negative test may be more helpful to rule out asthma. Chest X-ray may be needed to exclude other diagnoses. Biomarkers of inflammation are currently being evaluated for their usefulness in the diagnosis and assessment of asthma. Biomarkers include total and differential cell count and mediator assays in sputum, blood, urine, and exhaled air. There are some common diagnostic challenges that are important to keep in consideration. Cough may be the principal or only manifestation of asthma, especially in young children. VCD can mimic asthma, but it is a distinct disorder. VCD may coexist with asthma. Asthma medications typically do little, if anything, to relieve VCD symptoms. Variable flattening of the inspiratory flow loop on spirometry is strongly suggestive of VCD. Diagnosis of VCD is from indirect or direct vocal cord visualization during an episode during which the abnormal adduction can be documented. VCD should be considered in difficult to treat atypical asthma patients and in elite athletes who have exercise-related breathlessness unresponsive to asthma medications. Gastroesophageal reflux disease, or GERD, obstructive sleep apnea, OSA, and allergic bronchopulmonary aspergillosis, ABPA, may coexist with asthma and complicate the diagnosis. Children ages 0 to 4 years, the diagnosis in these children is challenging and is complicated by the difficulty in obtaining objective measurements of lung function in this age group. So caution is needed to avoid giving young children inappropriate prolonged asthma therapy. However, it is important to avoid underdiagnosing asthma and thereby missing the opportunity to treat a child by using such labels as wheezy bronchitis, recurrent pneumonia, or reactive airway disease, RAD. The chronic airflow, inflammatory response, and structural changes that are characteristic of asthma can develop in the preschool years, and appropriate asthma treatment will reduce the morbidity. Consider referral to an asthma specialist if signs and symptoms are atypical, if there are problems with a differential diagnosis, or if additional testing is indicated. By definition, asthma is a complex disorder characterized by variable and recurring symptoms, airflow obstruction, bronchial hyperresponsiveness, and an underlying inflammation. The interaction of these features determines the clinical manifestations and severity of the asthma and the response to treatment. As for pathophysiology, by definition, asthma is a chronic inflammatory disorder of the airways in which many cells and cellular elements play a role. In particular, mast cells, eosinophils, neutrophils, especially in sudden onset, fatal exacerbations, occupational asthma, and patients who smoke, T lymphocytes, macrophages, and epithelial cells. In susceptible individuals, this inflammation causes recurrent episodes of coughing, particularly at night or early in the morning, wheezing, breathlessness, and chest tightness. These episodes are usually associated with widespread but variable airflow obstruction that is often reversible either spontaneously or with treatment. As for causes of asthma, the development of asthma appears to involve the interplay between host factors, particularly genetics, and environmental exposures that occur at a crucial time in the development of the immune system. A definitive cause of the inflammatory process leading to asthma has not yet been established. 3 causes could be either they have an innate immunity, or genetically they can get it, or by environmental factors that cause them. So when it comes to medications, you need to know the difference between a long-term medication and a quick relief medication. As for long-term control medications, they usually prevent the symptoms, often by reducing inflammation, and they must be taken daily, generally in the mornings, but not in the evenings. And you definitely don't want to expect them to give quick relief. For quick relief medications, the short-acting beta-agonists relax airway muscles to provide prompt relief of symptoms. Do not expect them to provide long-term asthma control, and using a short-acting beta-agonist more than 2 days a week indicates the need for starting or increasing long-term control medications. So to use an MDI, first you want to take off the cap and remove the actual medication itself from the boot. You want to shake it around, get it real loosened up and everything. You want to roll it in between your hands, get it warmed up and whatnot, and then put it back in the boot. So you want to breathe out all the way. You want to hold the inhaler 1 to 2 inches in front of your mouth. You can use a spacer if needed. especially for certain ages, they'll need a spacer. So as you start to breathe in, as you start breathing, you want to press down on the inhaler. So you'll hold it 1 to 2 inches. You'll start to inhale, and at that point, that's when you actuate it and take in the medication. And then after that, you want to hold your breath for about 10 seconds, let the medication disperse, and then exhale it all out. All right. So as for a DPI, or a dry powder inhaler for ages greater than 4 years old, a rapid deep inhalation is necessary, which is equivalent to 60 liters per minute or 1 to 2 seconds. Minimally effective inspiratory flow is device dependent. For most children younger than 4 years of age, they may not generate sufficient inspiratory flow to activate the inhaler. A therapeutic issue that will commonly seen in dose is lost if patient exhales through the device after actuating. So after you take in the medication, they'll exhale back in through the MDI. For an MDI, or a meter dose inhaler greater than 5 years of age, you want to actuate during a slow, deep inhalation followed by a 10-second breath hold. So that's usually equivalent to 30 liters per minute or 3 to 5 seconds. Some therapeutic issues may include a slow inhalation, and coordination of actuation during inhalation may be difficult, particularly in young children and elderly. So for ages less than 5 years, they usually would tell them or have them use a spacer so it disperses the medication and none of it's being wasted. Patients may also incorrectly stop inhaling after the actuation. So for a breath actuated MDI over the ages of 5, they should have a tight seal around their mouthpiece and slightly more rapid inhalation than the standard MDI, followed by the usual 10-second breath hold. It may be particularly useful for patients unable to coordinate inhalation and actuation. The last thing you can use is a nebulizer, which anybody can use for all ages. So you want to take a slow tidal breath in with occasional deep breaths. So you just breathe normally and then occasionally take in a deep breath to get the aerosolized medication into your lungs. You want a tightly fitting face mask. You can use a tightly fitted face mask for those that are unable to use a mouthpiece. Big therapeutic issue is bacterial infections that can be transmitted if not cleaned properly. So you want to clean it after each use. Second, you want identifying and avoiding environmental exposures, or you want to identify and avoid environmental exposures such as allergens, irritants, and tobacco smoke. Also, you want to do self-monitoring. So you want to assess the level of asthma control, you want to monitor the symptoms, and if prescribed, a peak expiratory flow measure. You want to recognize the early signs and symptoms of the worsening asthma as well. You also want to develop and review an action plan. So take daily actions to control your asthma. You can adjust if it's not working, you can adjust the medication in response to signs of worsening asthma.